here. Thank you everybody for joining us today. So today is our lecture 5 of our geriatric resource course. So again, we're on the same page. We're sort of progressing from healthy aging through end of life right now. So we've had our first couple lectures were on sort of healthy aging and options and social determinants of health. Last week we talked about getting more into the geriatric syndromes and things like that. So today you are really lucky to have SFosnight presenting today on medication issues in older adults. Always, something that we've learned as we actually practice in real teams. It seems like no matter what the issue, if you're talking about falls, if you're talking about confusion, if you're talking about incontinence, there almost always seems to be some link somewhere to a medication issue that might be contributing to that problem. And again, we're not trying to turn anybody into a pharmacist, but we're just trying to increase awareness. Number one, of the fact that often, even though, you go to your doctor and you think, okay, I've been prescribed this medication, so I'm good. There are side effects and there are, things that you need to be aware of, and that sometimes the source of a problem might actually be the medications that people are taking. So just increasing awareness about that. And hopefully Sue's also going to cover some resources and things like that. And then as usual, she's going to talk for about an hour. Sue, would you prefer that they hold questions till the end, till you're done, or how do you want to approach that?
You can ask questions during. The one thing is if you I'll try to keep an eye on the chat. Sometimes
I'll do that. I'll do the chat.
So yeah, we can have questions as we go, and there should be, time enough to do it at the end too.
Yeah.
So.
And yeah, so at the end, if you feel like it can wait till the end, just go ahead and wait till the end. We'll unmute and then we'll just have like we always do, sort of have that open discussion. So I think with that, I will turn it over to Sue. Thank you.
Okay, so welcome everybody here and thank you for coming. So like Sue said, that I'm just want to raise awareness. So you already saw the videos that talked about the particular medications that older patients have problems with. And just kind of showing you the process that a pharmacist or perhaps a prescriber would go through as we decide what to do about these medications that may be causing issues in our patients. So we'll go ahead and get started. And a lot of times these are related to polypharmacy issues. That is what's going on. And for some reason, let me see, I think I got my arrows, there they are. So really, when we talk about polypharmacy, I'm just wondering what the group thinks, and you guys can either put it in the chat or preferably for me, you can unmute and say it. So what do you think is the definition of polypharmacy? Anybody have any idea?
Being on multiple medications at one time.
Yes, and that's what the name would imply. And the reason why I put this on here is because it's changed over the years. So I've been a pharmacist for more years than I'm going to tell you, but it's basically when I first started, it was the use of more than 5 medications, and they raised it to 6. Then they raised it to 10. And actually, for a while, it was just what you said, the prescribing of excessive medications. But now it's been changed again to the inappropriate use of medications. And actually, that's the one I agree with the most, because patient can be on 4 medications, but if it's the wrong 4 medications, they can still cause problems. So it's probably should have a name change of malpharmacy instead of polypharmacy, but it really, you'll find all those definitions in the literature. A little bit about chronic disease and polypharmacy. So certainly our older patients are very prone to have polypharmacy because as we age, we end up accumulating various different chronic diseases. But we do have some young patients that have chronic diseases also. And I just put the slide in because I think it's interesting that our young patients that have lots of medications, they end up benefiting from this type of approach, which has really been born more for older patients as well. And I used to work in a clinic that was called the high intensity clinic, and we did have quite a few younger patients, and it was surprising to me that applying these geriatric principles to to younger patients with chronic disease certainly had the same type of effects for them. So our results of polypharmacy, we have lots of things that happen as a result of polypharmacy. Basically, it's an increase in adverse medication effects. And we do know our older patients, just because they're older, are certainly more prone to adverse medication effects. If you watch that video, you could see that we have all kinds of reasons for that. So changes in the way the drugs are handled in the body, and then also just changes in what we call the physiological reserves. And our younger patients also have some of those changes in physiological reserves, which is why some of the geriatric principles probably work for them. There are basically, I have some statistics on here. Adverse drug events are responsible for 5 to 28% of acute geriatric admissions. And about a third to almost a half of these reactions were found to be preventable. And again, so making it very pertinent to the fact that we apply these principles of assessment to look for these effects so that we can prevent these adverse medication effects from causing big problems. And the big problems that we can sometimes see are decrease in function, decrease in cognition, and increase in falls. And definitely all of this increases healthcare costs. And we also see an increase in non-adherence. So many times patients will recognize that this medication does not make them feel well, and they will quit taking it. But a lot of times they don't share that with the prescriber. So I wanted to just go through a sample, and I can't remember if this was in your introduction materials or not. But this was a patient that I came across a few years ago. They were on amiodarone 400 twice a day. Now, I don't know if anybody on the call might know what you think about that dose of amiodarone. I heard there were going to be a couple of nurse practitioners. I'm not sure. Anybody have any idea about the amiodarone dose? All right, well, it's actually a loading dose for a patient. So amiodarone is a drug we use for cardiac arrhythmias, and it's a loading dose. So usually it's given for 2 to 3 weeks, depending on the patient's weight. But this particular patient actually had an error occur where they were continued on this amiodarone long term. And when you continue the amiodarone, a lot of times you will get more central nervous system effects as the levels increase. And it's kind of a subtle reaction because amiodarone has such a long half-life that you don't see the full effect of amiodarone for about 2 months. So this patient started to have a tremor, which is pretty common when you have too much amiodarone in your body. They also had some slowness in their movements. So a tremor plus that slowness in movements is a clinical diagnosis of Parkinson's disease. And they got started on a Parkinson's disease drug, carbidopa-levodopa. And the dose was started at 10/100 4 times a day. So that carbidopa is the first part of the drug, the 10 part. And we do know from studies that we need at least 50 milligrams of carbidopa in the body to prevent the side effects from the levodopa and to prevent it from metabolizing before it gets into the brain. So this patient wasn't quite is supposed to be 75 milligrams, not 50 milligrams. So this patient was not quite on that amount. And they did have a side effect from the carbidopa-levodopa where they got very nauseous. And that nausea occurs because the levodopa is being metabolized in the periphery instead of in the brain. And 2 things can happen. You can get nauseous. You can also get low blood pressures. So for this patient, promethazine was started. And if you watch that video, promethazine is one of those drugs that have a lot of side effects in older patients. And this was an older patient. So it blocks the cholinergic receptor. And the cholinergic receptor is already kind of depleted just because as we age, we lose some of those receptors. So this patient actually had those anticholinergic side effects, which one of was that it could cause falls, it could cause confusion, incontinence, falls, confusion, it can cause constipation, it can cause some vision changes. And this patient actually had basically the issues with the confusion, and I saw them when they got admitted to the hospital. And at that point, they were adding some donepezil, thinking that this was dementia rather than the delirium it was. So you can see this poor patient had so many side effects from medications, and that kind of built up their list. So one of the things that we talk about is when we're looking at medication lists is, are there side effects that are happening that haven't been recognized and that we've added another drug to? And this is called the prescription cascade. And it wasn't coined by me. There is somebody named Dr. Gurwitz who came up with all of this. And what he said was to avoid the prescription cascade, to treat each new symptom as an adverse medication effect until proven otherwise. So if a patient has a new symptom that's occurring, look at the medication list to make sure it's not a side effect from one of those medications. Oftentimes the medication can be changed, or we can come up with a way to deal with the side effect that would be better for our older patients. So as you're reviewing medications, there's several ways that are that have been published about how to assess for polypharmacy. So the first one I have on the list here is the Good Palliative Geriatric Practice Algorithm. This is a great algorithm to use for patients that are close to the end of life. So it really goes through weighing the benefits versus the risk of many of those medications that we might start to peel off towards the end of life. The next one is called ARMOR. And ARMOR is something that I've been using for years before it was called ARMOR. So it's assess, review, minimize, optimize, and then reassess. And then we're going to spend most of our time today talking about this ARMOR way to look at medications. And then there's also the deprescribing protocol. And this also kind of is incorporated into ARMOR, is to list all the medications and indication for each med, risk to patient, risk of each med, and prioritize for discontinuation, then implement a drug discontinuation plan. Now, there is a website that I wanted to mention to this group, and this is probably the best place to do it. It's called www.deprescribing.org. It's open to anybody. You don't have to register to use it at all, but they got a grant, and what they're doing is they're going through, I believe it was 28 different med classes that they're going to reviewing the literature and really trying to come up with directions on how to take patients off medications. Because one of the issues that we have is the manufacturers certainly are very specific about how to put a patient on their medication, but they are pretty vague usually about how to take somebody safely off the medication. And since our older patients are more prone to have withdrawal symptoms like side effects from medications, we want to be very careful about how we take people off. And from what I've seen, from what this group is doing, that they're doing a great job with making sure that we minimize the chance that the patient has withdrawal symptoms. All right. So going through this ARMOR system, the A basically says to assess. So one of the first things we want is an accurate med history and a medication list. And then to assess for adherence issues, for any types of symptoms they're having or adverse effects they're having. The next thing we do is review each medication for appropriateness, effectiveness, safety, and adherence, and then evaluate the benefit versus the risk. Next is that we want to minimize and optimize. So sometimes with polypharmacy, when we're reviewing it, we actually add meds rather than take it away. It really kind of depends on what's going on with the patient. So if we have a medication that we think will help the patient either prolong their life or help with the symptoms, we might add at that point. We also would develop a plan. So when we minimize and optimize, you can't change everything all at once. Sometimes there's lots of changes that are needed. So we're going to normally do our changes slowly, one at a time, prioritizing which is the most important. Sometimes when a patient's in the hospital, we may do it a bit quicker. And sometimes if the patient's having serious side effects, we're going to have to do more than one at a time. But if possible, you want to just take away one drug or add one drug at a time so that you can see the effects of doing that for the patient. And then the last step here is also very important, is to reassess. So make sure we see the patient back to see what happened and that they did okay with the changes that we're making.
And so can I interrupt for just 1 second? I want to remind the group that we do have a variety of learners here with you. So if you're, maybe not so medical, please listen to this as an informative. This is what pharmacy adds to the care of an older adult. Don't be focused on the details, right? But we do have, as Sue mentioned, some advanced practice nurses, et cetera, who may be getting a little bit more out of this one. So each lecture might apply a little bit more or less to you personally. So I don't want anybody to be thinking, and certainly not suggesting that you would then, be going and maybe discontinuing medications for people as well. So I'm sorry, Sue. I just wanted to, I
No,
didn't
that's
want people to
okay.
be like, this is, not
Yeah,
me.
and it is a little bit technical, but I think the other point to make is that it also gets you an idea of, maybe when you should ask for medication review for a patient. So
Yes.
certainly wouldn't expect people to do this on their own, unless you're a prescriber. All right, so moving along here, I just want to we're going to kind of go through this case. So this is our patient. You can see they're on a whole bunch of medications. We'll talk more about those later, so I won't just read through them, but this is an 82-year-old Caucasian female. She has COPD, hypertension, diabetes, chronic back pain, depression, and anxiety. We don't know her family history. She's a previous smoker, occasional alcohol in the past, but no alcohol now. She lives alone. The daughter checks in with her once daily, sometimes by phone. She does have a Lifeline alert. She doesn't have any allergies. She's caught up fairly well on her vaccine. She could probably use another COVID booster. Her pertinent symptoms are she's positive for pain. The rating is 6 on most days. Her diarrhea is not new. She has fatigue, she has some dizziness, she has gait problems, and she has a dysphoric mood. And all of these have been going on for a little while, so none of them are real new. So her vitals, and I did update these so to make this look more current, but you can see her blood pressure is 151/75. She's had lower blood pressures before. So we know that her lab values are within normal limits, except for her hemoglobin A1C is 7.8, which is okay for a patient her age, as long as she's not having symptoms. And for those of you who aren't medically oriented, the hemoglobin A1C measures how well her diabetes is doing. We can also see that she's doing okay as far as her cholesterol. And her vitamin D level is just a little bit low. All right, so one of the first things that we do when we're looking at medication regimens is to divide the medications into everything that they're doing. And the reason why we do this is because it's hard to look at what's missing or what's extra if you don't really look at it from the point of view of, okay, what are we treating each disease state with? So this is the way that a pharmacist would normally do it. Now, this next question I wanted to spend a little time on. So what do you think is the average number of errors on an initial medication history that's done? Anybody have any idea?
3.
Very good.
I was gonna guesstimate too on that.
Yeah. Yes, and that is the correct answer. So there is an average of 3 medication errors on an initial medication history. I believe it may be more for our older patients. The studies that did this had both young and old patients in it. But I think the very important part of that is that if you know of a patient that is going to a hospital setting or to the doctor's office, it's very important to bring an accurate medication list. And it's honestly somewhat hard to get an accurate medication list from many people. So a lot of our older patients are not taking their medications themselves. They're basically being supplied in packaged information, or they have a caregiver that's helping them with their medication. So identifying the person who is actually giving the patient the medication is sometimes the best way to get that. And making sure that the medication list is kept up and accurate is important, because if you don't have an accurate medication list, then really it's hard to come up with a good plan for the patient. We always say, we don't have a garbage medication list, then we're going to end up with a garbage plan, because it just doesn't work. The things that people often don't tell you about are their OTCs and their herbals, inhalers, the patches, the refrigerated meds. So I think there's a few care managers on the line also. So those are, you guys, I know, take those medication histories. So making sure you ask about those things is an important thing, so that we have a good knowledge of what the patient's actually taking. So the next thing that we wanted to do with this particular patient is to really find out if we had an accurate list. And for this patient, I had students with me, and we did go in and talk with the patient and the patient family, and we found some missing drugs. So that she was supposed to be on tiotropium. She took insulin, ibuprofen, and calcium citrate. So kind of fits into those things that people often leave off. They often leave off things that are not just something that you would put into a pill box. So the inhalers, refrigerated items, OTC products. The next thing we want to do is to review for appropriateness, effectiveness, safety, and adherence. So I'm going to just talk a little bit about each of those. So in our geriatric population especially, but also our younger patients with chronic disease, it's good to ask about the geri syndromes. A lot of the geriatric syndromes are actually adverse effects of medications, or are at least aggravated by the adverse effects of medications. So we want to know, has the patient fallen? Are they in pain? Is it controlled? Do they have anxiety, depression? Are they having problems with cognition, incontinence, any insomnia? So those are things that we need to know that helps us to screen for adverse effects. The next thing we want to do is to screen for adherence. So many people have problems with adherence. And actually, Sue Hazlett and I did a study a long time ago about medication adherence, and we looked at the reasons why patients have problems with medication adherence. And I would say most patients are not completely adherent with their medications. It's important for us to know the reason for the non-adherence so that we can come up with the correct solution. So, for instance, if the patient is not taking their medications, a lot of times we might jump to, well, let's go with DocuDose so that they'll remember, it'll be more organized for them. And that certainly is a good option if organization is the issue. But if they're not taking their medications because they're afraid to take them, or they're having side effects, then moving them over to DocuDose isn't going to do anything. So I asked these questions, and I've made a mnemonic for me so I can remember it real fast, and I teach this to my students as well. And actually, we just published on it not too long ago. So the mnemonic is cost B. C stands for cost. So I usually ask an open-ended question. It can be different depending on the patient, but just something to get them talking about whether they're having problems with cost. So usually I say, I pick out one of their medications, or you can just say medications can be very expensive. How do you manage to pay for all these medications? So patients will either at that point say, oh, I have really good insurance, I don't have any problems at all. Or they'll say, as a matter of fact, I don't use this inhaler because I can't pay for it. Organization is the next, that's the O part. So how do you remember to take your medications when they are due? S is for, and organization, I oftentimes have to give an example. Do you use a pill box? Do you have anything that reminds you to take them? S is for side effects. So what side effects have you had from your medication? T is for transportation. How do you get your prescriptions from the pharmacy? I've had lots of experiences with patients where they basically have limited mobility. They don't drive, and they have somebody that comes in to help them, a family member most often, maybe once or twice a week. So if they get a new prescription, they just wait until that person comes. And that might be okay for some prescriptions, but if it's an antibiotic, it certainly is not okay. So making sure that they have a way to get their medications quickly. And then B, so what is the benefit of therapy? So which medications do you feel are helping you, and which do you feel are not helping you? So you get some idea, and a lot of times patients will say something to me like, well, I'm taking this one medication for my blood pressure, but it doesn't seem like I feel any different when I take it. So I just quit taking it. So that would be, an area for us to educate, but they're not going to feel different, but they'll live longer if they keep their blood pressure under control, or they're more likely to live longer. And then I ask a question that says, I know it must be difficult to take these medications. About how often have you missed the medication within the last week? So getting some idea if they're actually taking the medications. And I find this to be very important information before I decide that I need to change something. All right, so some of the tools that are out there to improve adherence, if you're working with patients, you may already be aware of some of these, but if not, perhaps they'll be helpful for you. So we do have the goodrx.com, which I think most people know about, which is just a place for you to find what the cost of the medications are at the various different pharmacies. We also have, there is a formulary, it's called Coverage app, and it's actually called Coverage, and it can help to find if the patient's insurance covers the medication that was prescribed. For if the issue is organization, and I left off the needymeds.com. I use needymeds.com all the time for my older patients particularly. So many medications will have a program where the patient can get the medication for free from the manufacturer. And it's different with different meds, but many of the meds go up to $50,000, $60,000 a year. So if a patient is just getting Medicare, they're probably not making $50,000 to $60,000 a year. So they probably qualify for that program. Has the downside that somebody needs to fill out the forms and get them sent in. But then the patient does get medications, usually a year at a time, and then they might have to reapply for it. So something that for our older patients, many do qualify. For organization, we have pillboxes, compliance packaging. A lot of people call that DocuDose, calendars, reminder apps. The reminder apps are usually something if somebody has a smartphone. MMS Plus, which I listed first there. There's also Pillminder and Round Health. I've looked at all of those. I like MMS Plus the best. It takes a little time to set up, but it's actually a very nice program for the patient. Side effects. So if the side effects is the issue, trying to come up with alternate timing and alternate medication, a way to treat the side effect. Delivery services can help with the transportation issues. So there are a variety of pharmacies that will deliver the medications these days. So getting the patient involved with one of those pharmacies can help to make sure that they don't have to wait for the medication. And then education will help with the benefit for therapy. So making sure that the patient understands the difference between symptoms, and then more of some of the medications are to try to ensure that they have the longest life possible. All right, I just listed out some of the adherence aids would be pill boxes, but there are things that get a little bit more fancy. Let me see, there it goes. So there's the electronic adherence boxes. So these are things that you can set up usually for a week or two at a time. A lot of times insurance does pay for a nurse to come out and set it up. Not all insurances do, but a lot of them do. And then the medication basically becomes available at the time that it's due. So it's kind of a little computer in it that you program. And then after, you can set for how long you want it to be available, and then it pushes it away so that the patient doesn't take double medications. There's also all kinds of other fancy things. There's this RX timer cap, which basically you put a special cap and you can keep track online how often the patient actually opens it. Doesn't really tell you that they took it though. And they have those types of caps also for inhalers and for injectables as well. There's also these bioingestible sensors where they put a sensor in with the medication. I haven't seen anybody ever do that, that you can track that the patient actually took the medication. There are some remote monitoring things that we do. So you probably are familiar with the more with the blood glucose monitoring, because it's really come a long way in the last 3-4 years. Freestyle Libre, Dexcom, it's very good to know that most insurances are now covering that, so that the patient doesn't have to prick their finger anymore. They can just use basically a patch that they use a reader on, and that reader gives them a value, but it also is a value that when downloaded, that the provider can review as well. There's home blood pressure monitoring, and there's also, we can have home health nurses go out to monitor vitals and draw labs when we need to as well. And then there's these even more high-tech things, the smart watches or devices, the Medtronic, where you can measure blood pressure, pulse, and more really these days. And mobile health, eye health systems, which again will monitor a variety of things. So we have lots of ways to remotely monitor. All right, so getting back to our patient, I just thought I'd share a little bit more about this patient. So this patient has an albuterol inhaler. She uses it at least 3 times every day, which is a lot to use an albuterol inhaler. We'd prefer patients to not to need to use that more than a couple times a week. We have aspirin that she started. She started at 20 years, kind of on her own to prevent a heart attack. She's also on metformin, carvedilol, lisinopril. The cyclobenzaprine was a medication that she takes 3 tablets every day, 1 tablet 3 times a day. She feels it helps a little. She was taking been taking the cyclobenzaprine, wasn't helping enough. She went to the doctor, and her perception was that that he added the tizanidine. So he basically decided to, along with the cyclobenzaprine, for her to take the tizanidine. And she does get some effect when both are taken at the same time. Now, we called the physician's office, and the intention was for her to stop the cyclobenzaprine. And this is another one of those things that can happen with patients, is that basically we can see some problems with when patients stop a medication. The physician can't really send anything to the pharmacy that tells them to stop it. So it's important to let the pharmacy know that the patient doesn't take that anymore, so it doesn't accidentally still get filled. And I come across that, you know, here and there, that patients are taking double medications because one thing was stopped, but the refills kept on going. She's also on something for her cholesterol, the atorvastatin, which she started 5 years ago. And then she took something for her stomach, the omeprazole, and that got started in the hospital. And it really has never been stopped since that, but she doesn't really have problems with heartburn or anything. All right, so she takes some loperamide, which other name's Imodium. You may recognize that as an OTC product to help with diarrhea. She takes that every day. She's on sertraline. She's been on that for 10 years, and that's an antidepressant. She recently added a second dose because she was having more trouble with depression. She's on a medication called alprazolam. That's in the benzodiazepine class of medications. It's a drug that often causes falls in our older patients. All the drugs in that class do that. And it's very addictive. And like many people, she said, I don't care if you change anything, but do not take away my alprazolam. And that means that she's probably withdrawn from that before. You have to decrease that dose very slowly for patient not to have symptoms of withdrawal. She's taking the vitamin D. She started that for a fall. And the trazodone, she's used that for quite a while for her insomnia, but it's not working anymore for her, and she's not sure why. The tiotropium, which is a Spiriva inhaler, she has an active prescription, but the price went up. She ended up getting into her Medicare gap, or some people call that the donut hole. So she can't afford to pay for it anymore, which is why she's probably using so much albuterol. The insulin glargine, she takes that at bedtime. She's been on it for about a year, but she often falls asleep before she takes it, and she misses it about 4 times per week. The ibuprofen, she started that on her own. That's, you might know that as Motrin or Advil. She takes 2 tablets twice a day. And as we know, if you remember from that presentation, you may or may not, is that it has a lot of side effects for our older patients. So we normally try to avoid that in our older patients. And she does take calcium for her falls prevention, or really it's fracture prevention. So talking about the other things that we said that we would assess, she reported the insulin was off and missed last week. The rest of her medications she takes regularly. She can't afford her tiotropium though. She has a pill box that her daughter fills, and she states she rarely misses the meds that are in that box. She does get very tired when she takes the cyclobenzaprine and tizanidine. She always just takes them together. They do make her feel dizzy as well, and usually she falls asleep after she takes them. The daughter obtains her medications on the weekends. If she runs out of something, she just waits until the weekend. She doesn't get much relief from this. For benefit, she doesn't get much relief from the cyclobenzaprine and the tizanidine. She's had 3 falls in the last month. She came to the hospital once. I use a quick screen for pain. So the P stands for palliating or provoking. So what helps the pain and what worsens it? She says ibuprofen helps it, and moving worsens it. Q is the quality. She says it's aching and shooting and sharp. The R is for the region. It's in the back, achy. Well, I don't know why I put that twice, but it's in her back. S is for the pain score, or the severity. Her pain score on most days is about 6. T is for what temporal or what time of the day does it occur. It can occur at any time of the day. And U is for how does it limit the patient? How does it affect you? So it limits her movement. For her anxiety, and you can see these are the Jerry syndromes. She sometimes has anxiety, but she does get benefit from the alprazolam. For her depression, you might have heard in the last one about the PHQ-9. So if you don't know what PHQ-9 is, it's just a way to assess depression. And her assessment was positive. And her sertraline had been increased within the last month to Q12 hours from just once a day because of that. Her mini-cog was negative, and mini-cog again is an assessment that assesses cognition. It's a fast assessment for cognition. She is continent. She has trouble with insomnia. She's had this for years, but it's been worse lately. And as far as patient goals, one of her daughters lives in South Carolina, and she'd really like to see her daughter go visit, but she doesn't think she could make the trip. All right, so we are at the stage now of the armor where we've already done the assessment, we've reviewed each medication, and now we're going to minimize or optimize. And develop a plan to do that. So really, when we're talking about minimizing or optimizing, we are looking at weighing the benefits versus the risk. We're going to think about, does this medication still fit into the patient goals? If so, is it causing irritating or harmful effects? And if so, is there a lower risk alternative available? So like Sue said, I don't expect you to be pharmacists, but you may have some input into this. And what I have up here is just a list of the patient's medications. And remember that a lot of times we can solve these medication issues by things that are not medication. So there's other things that may be done as well. So I wanted to just open up to the group, and it can be, you can just basically feel free to say anything that you might think that might help this patient, whether it is medication or something else. Anybody have any ideas?
I have an idea. Can we switch the ibuprofen to Tylenol?
Very
And-
good.
And you
Yes.
also say the albuterol inhaler is not doing much good. That's not doing good for it, taking it 4 times a day. Can we limit that to once in the morning and once in the evening?
Yeah, so I like both of those ideas. So that ibuprofen to Tylenol is kind of our classic thing we do for pain in older patients. And I cannot tell you how many people that I have said, well, we want to switch your something to Tylenol, and they will tell me Tylenol doesn't work for me. I'm not sure why, because it doesn't make sense pharmacokinetically to me. I'm convinced there might be an active metabolite we don't know about. But I will tell you that if you take acetaminophen on a regular basis, it takes approximately 2 days to kick in, but patients start to have effect from that. So I always feel like I'm kind of selling acetaminophen to educate patients that just try it for 2 days and see if it helps. Because ibuprofen has a lot of side effects. All the drugs in that class, ibuprofen, naproxen, which is available without a prescription as well. Those all basically can cause, for our older patients, a water retention, which if they have CHF can cause them to have a CHF exacerbation. They also will increase blood pressure, so they can cause hypertension to go up, to be uncontrolled. And then they also have a cardiovascular risk. So we know that patients that take those drugs are more at risk for a cardiovascular event than patients who do not take those drugs, older patients. I'm only talking about older patients. And then
Can I ask you a question about the inhaler? Is that a rescue inhaler or is that a daily inhaler?
So the inhaler is a rescue inhaler, and she can use it up to every 4 hours as needed if she was having an acute event. But it's not meant to be something that she's taking on a regular basis. So, so I agree that now that albuterol, I wouldn't expect you to know this, but it can cause patients to be anxious. So if you take an albuterol inhaler, you're going to be anxious for a little bit after it, 30 minutes to 60 minutes. So it's probably contributing to her anxiety. And the fact that she can't pay for the tiotropium, or Spiriva is the other name, using what we call a maintenance inhaler, which is a long-acting inhaler, and it's going to basically keep the levels just kind of steady. So not using that is causing her to have to use the albuterol more. So, so one of the things to think about is how can we get her an inhaler that she can afford?
Right, because I know my daughter has asthma. She has an inhaler she uses once a day. I can't think of the name of it right now. The albuterol is just her rescue inhaler she uses in case she needs it.
Yes, and that's how it's supposed to be. But then, you're going along and you're doing what you're supposed to do, and all of a sudden it gets to be July, and they tell you you're in your Medicare gap, and your tiotropium, which used to cost you $20 to $40 a month, is now going to cost you $300 to $400 a month. So a lot of people, they can't afford it. They just don't take it. And they also don't realize that they probably qualify. I mean, many people will qualify for the free manufacturer programs. And so that's another place where, and our retail pharmacists, our pharmacists that are in the community, they don't jump into that too much, but certainly the pharmacists that are involved in the doctor's office. And it's something to tell patients, you know, to call your doctor's office and ask them if there is a way for you to get this medication less expensive. So the patient can start it, but the doctor will need to sign it.
Okay.
Terrence, I see your hand up.
Yeah, I got a comment and a question. I'm like, first, the comment is I'm stunned that the patient has all these medications. I'm like, this is really I can't imagine, first of all. So I'm really, you know, and I'm very new to this. I'm green in this whole, so I'm really stunned that she's on all these medications. My question is that, wow, I mean, and plus the cost of all this, I can't even imagine, but it seems like there should be, when we talk about pulling them back off the medications to some degree, that we might want to even look at some more holistic kinds of practices that are not as, you know, addicting, not as, you know, invasive, not as harmful. I mean, why would we not want to say, hey, you know, I mean, the technology is out there. They got stem cell, you know, technology in the form of patches. They got acupuncture. They got all these different other things that, why would we? I'm like,
you know, I can't agree with you more. And I will start with your first comment. This is not unusual. I do this all day, almost every day of the week. And it is, it's really common to have this type of a regimen when you have these types of chronic diseases that are going on. So the reason, and this is just my opinion, but the reason why less of the holistic type of things are doing, and I agree that there's a lot of ways that we could be treating some of these things, especially the depression, anxiety, that doesn't get done is it's not covered by insurance. People can't afford it. So, you know, they can't really afford to get acupuncture because it's not covered and it's expensive. But it does have studies that show. So really, you know, making the insurance companies aware of the benefits of things and doing the studies to show these things work. I mean, just like the Freestyle Libre, which I don't know if any of you are familiar with it, but it's really a breakthrough where you put a patch on and you don't have to check your sugars anymore, and you can just use a reader. But not only that, but it keeps a continuous record of your blood sugars that can be downloaded to your provider that would then be able to figure out what the best regimen for you. That's a huge breakthrough, but it's been out for about 4 years before. We used to really have to argue to get it for patients, but now people have done the studies. They show that people stay out of the hospital. They do better with it. So you got to spend money sometimes to save money.
So if you got to spend the money, if you got to spend money, and when these medications get to a point where your insurance is not covering, you still got to kick in this other money. It's like, okay, if you're going to spend this other money, you might as well spend the money on some other
That works.
options that work and that, oh my God. Okay, I'm
and
done.
also advocate for those other things to be covered by insurance, because there's a lot of things that would help patients that aren't covered by insurance.
I'm
Very
gonna
good
start
comment,
praying.
though. I appreciate
I'm about to pray for her because I'm sad right now.
Me too, Terry. I feel you. I feel you. It seems to me, and this is not a put down or a slap in the face, because I know every profession, there's somebody who really does care, every profession. But it seems like in the medical field, so many people who have the power and the prescription pad and all these other things that almost control people's lives. It's like the older people. I'm scared. I'll be 66 in April, and I'm scared. You know, it's getting scary to me because it just seems like people who should care, who signed up to care, don't really care about older people. It's like you have lived the better part of your life, and plus somebody else's, you may have gotten 10, 20 years of somebody else's life. And it's like they just don't, people just don't seem to care.
I think that people do care. It's taking care of older patients is a lot of time to do it the way that it really needs to be done. So I do think we have specialists, we have the geriatricians, and I do encourage that, you know, if you start to have chronic disease, getting the geriatricians involved. They do a similar thing to what I'm doing. And then there's the clinical pharmacists that basically, if you go to your pharmacy, you can ask if they have available a way to do a medication review. And then they'll work with your regular physician to do that. So I think that they start out caring, but there's a lot to be done.
Right,
And a lot of
right.
times I feel like people,
know.
and some of our physicians may not be as in tune to these side effects that these drugs can have for our older population.
Mhm.
Well, that part of the problem I was going to say, so Michelle, I see your hand up. You break in after I'm done, but so part of the issue and part of what we're trying to do in this course is like, there isn't a lot of training in geriatrics, or the country is very sorely lacking in geriatricians. We're lucky sort of in the Akron, Cleveland area that we do have more kind of than our fair share, but go anywhere else in America and it's very hard to find somebody who is a geriatrician and or has much geriatrics training. And as you can see, and as you learned just from Sue's own lecture and then from Amanda's last week, right, there are all these issues that are very specific to older adults, and sometimes they just don't know. They don't know that, you know, you've been on this medication for 20 years and they maybe don't give it a second thought about those changes that are specific. So that can happen too.
Right.
Michelle, your hands up been a while, and then Terry, go ahead and follow up from her.
I'll go first since she didn't answer yet. This is
She's
Terry.
muted. You're muted, Michelle.
Okay, I was saying, Terry, I understand how you feel,
Okay.
but at 48 years old, I had a stroke. And what ends up happening is you have multiple specialists that you're seeing for different things. And so these people, what I learned is that it's important with elderly people to have someone go with them to their doctor appointments and who can keep track of their medication and help them understand too better what they're taking, why they're taking it, why it's important that they continue to take it, why it's important that they talk to their doctor about side effects and updates and things like that. Because they don't remember from one appointment to the next sometimes what happened with new medication or how it affects them. The lady, one of the ladies I take care of, she's 95 years old. She takes that, she only takes 2 major medications, and that's good. When I was 48 and had a stroke, I was taking 19 medications. Okay. So I'm just saying.
They add up, and you give such good advice that it's a really good point that a lot of older patients won't remember their side effects to report.
They will not.
And they're also, I mean, if you're in that older range, 80 to 90, a lot of people don't want to like say too much to their doctor, you know, offend their doctor about prescribing things. I've run into that. Well, I don't want to tell my doctor that, but you know, they need to know. So you have to encourage them.
So this is Terry. So she's on a lot of medicines that can make you sleepy. So the sertraline can cause drowsiness, the alprazolam, the trazodone, alprazolam is on there twice. So, and the cyclobenzaprine too. So if those could possibly be changed out for something else, that would be helpful. Also, I think people forget in senior citizens that you can offer therapy to them, and a lot of them will accept it. So that might be helpful for her in terms of her depression and anxiety.
Gary, absolutely. Now, sertraline, only thing I will say about the sertraline, it's usually a little bit activating in most patients, although it can be drowsy in some, but she's taking the sertraline at bedtime now. which probably is causing her to stay awake. Why the
Why
trials?
is she taking a Q12 hours? That's another thing. Like a lot of her meds are BID that don't need to be BID.
Yep, the lisinopril and the sertraline. Yep.
Yeah.
I mean, I didn't change those. This is just how it was. I
Yeah.
imagine that sometimes people divide doses thinking that they'd have less side effects, but
Yeah.
I don't see that. I see it sometimes, but not that often. But that sertraline at bedtime is definitely probably causing her some insomnia. And I agree, she's on a lot of medications. That cyclobenzaprine, she was supposed to have stopped that.
Yeah.
It's just an error that she's on it. So getting her in, like I said, you can't do it all at once. So deciding which one's the most impactful to her and getting
Yeah.
those off, coming up with a plan on how to do it is important.
Yeah.
And
I
I
wasn't-
really like that you said therapy because
Yeah.
I mean, definitely counseling works for depression and anxiety. I put them on twice because they're being used for both depression and anxiety, and counseling does work. So some older patients don't want to do counseling. I think now that a lot of the counseling is being done by telehealth is helpful.
Yeah.
More patients are willing to do it over the phone or over a computer.
Yeah.
So
I
great.
Also-
wasn't finished with what I was trying to say. The last thing, and this is it, I'm not sure how to pronounce it, atorvastatin. If she's already
Yes.
having problems with dizziness and her gait, then that medication particularly makes them dizzy. It causes dizziness.
Yeah, so the atorvastatin or atorvastatin,
Yeah.
however you want to say it, it basically is for cholesterol. That one's for cholesterol.
Mhm.
And you're right. I mean, it's kind of weighing the side effects of that medication. So most of the time I don't see dizziness too much, but definitely it could be contributing to her muscle issues. And there's a way you can just check a blood level. It's called a CPK level to see if that might be contributing. Because we're always weighing, there's a lot of studies out that do show that medication will prolong life. And they used to be, they weren't sure about in older patients, but they've done the studies and yes, it does help. It prevents you from having a stroke or a heart attack. But if you're miserable every day, then you might not want to take that anymore. So really, that's that weighing the benefit versus the risk.
So one more thing about the Spiriva. You mentioned a lot of good ideas about getting discounts for that, but also at the pharmacy, because my mom is on it and it's very expensive. They have those little RX cards by the checkout at the pharmacy. And a lot of times that can like cut your medicine to like a third of the cost.
Absolutely. So those are called Good RX.
Yeah.
You can download the app, and if you have a smartphone, I highly recommend the app because then you always have your phone with you, and you could just take it to the pharmacy with you and see if there's a coupon that will decrease the cost of your medication. So, and they do have a lot of coupons that do that. So that's a great idea also.
Right.
Okay, go ahead and.
Okay, I was looking at the orphan medications. I know what omeprazole is. What is the other one?
Loperamide?
Yes.
Yeah, so both of those are available without a prescription. So Prilisac is the other name for the omeprazole. And then loperamide is Imodium. So the omeprazole is a drug that decreases the acid in your stomach. It's usually used for patients who have heartburn, but we oftentimes use it in the hospital as well, because if the patient's in the hospital, they can actually have more chance of getting an ulcer. But in this patient, it didn't get discontinued, and it's a high dose. It probably needs to be discontinued. Using it long-term can contribute to fractures, which is, and she is at false risk, that's kind of newer information that everybody doesn't know, but definitely very pertinent to our geriatric population and something I'm often working to get the patient off that medication, if she's not really having that issue. And I call it an orphan medication because it doesn't really have a diagnosis to go with it. Now, the loperamide, she has diarrhea every day. So you kind of wonder why she has diarrhea every day. And she is on the metformin. And I don't know how many of you are familiar with metformin for diabetes. Excellent drug, has great results, but its major side effect is diarrhea. And you can overcome that diarrhea just by giving a medication called the metformin XR, the long-acting version, has much less diarrhea, still good outcomes. So that's an easy fix, to just change her metformin to the XR form. And then we would not have to give, hopefully, the loperamide. You guys are catching a lot of these. Any other comments?
Terrence did have a question about whether SUMA has anything regarding homeopathic medicine.
As far as, not that I know of, as far as a way to be involved with the different homeopathic medicine type of areas, not that I know of. I mean, I would love to have a place to send my patients for some of those things that was paid for by insurance. I mean, we do have some providers, but it's expensive. A lot of people cannot afford it.
And like Sue said, the actual science showing the benefits, a lot of what the evidence is just sort of word of mouth, right? This worked for me, that worked for me. But the actual studies of these various methods of pain management or chronic illness management have been less well studied, although that's improving. There is more funding now around studies that do investigate these types of things, but it's been slower. The drugs and stuff definitely have more money behind them. And that's kind of why the go-to treatment is that direction.
And Sue, I have a question, not so much with the med list, but maybe it's a good time right here to ask. So you do these assessments in the hospital, but how would somebody go about accessing a pharmacy review, in the community? Or is there a way to do that, or through their physician? Would they request it there? How would they go about having somebody look over their med list?
So there are several different ways. So certainly some physicians do have a pharmacist within their office. So for instance, right now I have my partner, Dr. Marciano, and I are covering our house calls service for doing these types of med reviews. We have the special care clinic where there's a pharmacist involved with those patients as well, doing these med reviews. We have the cardiac area at SUMA that has pharmacists involved as well, probably doing more of a cardiac focused review. We have the internal medicine clinic where there is a pharmacist that doesn't do those reviews for everybody, but does do those reviews upon request. So there are different areas that have a pharmacist involved. But anybody can also go to the their pharmacy. And I would say most of the Giant Eagle pharmacies, it really, I think the Rite Aid pharmacies, it's variable depending on the particular pharmacy. So you would have to call your pharmacy and just ask for a medication review. So Medicare Part D, as long as the patient has Medicare Part D, they will pay for a medication review by a pharmacist. And if you didn't want to go through your pharmacy, or maybe your pharmacy does not do this, the Neomed actually does have a clinic that does these medication reviews for patients that aren't getting them done in the pharmacy. So there are ways to get that done. And I will say, Terrence, thank you so much for the website. I'm very interested in that.
Does anyone in this lady's family, her daughter or daughters or anybody that's connected to her, do they ask questions about, like we're asking, about all these different medications that she's on and these different things like that? Do they do any research? Do they do any kind of follow up with this, all this stuff that's going on with this lady?
So I did talk with her daughter. So this was a patient in the hospital, so I didn't have as much follow-up as if it would have been one of my clinic patients. But I did talk with the daughter. We did share this, by the way, our assessment we did share with the primary care physician. And I did talk with the daughter about the fact that some of the medication issues. The daughter basically filled the pill box. And like a lot of family members that I talked to, they weren't really, this is information that they just have no idea about. So I let them know that we sent some information to her physician and to be sure to ask the physician about it. Now, if you get a medication review that's done in the community, not only does that go to the primary care physician and maybe to some of the specialists, but it can also, there's basically a form that goes to the patient as well with a summary of the things that need to be asked at the doctor's office.
Okay, thank you.
I think,
Go ahead, and John, go ahead.
Trying to unmute. How you all doing today? What does a nutritionist say about the diet? And I guess I know you were saying it's not many studies on this homeopathic, but from the things I've been reading about the way you eat, what you eat, bringing more oxygen into your body, and even though we're talking about elders, that their bodies still are operating at a level which can start to heal itself. So is the nutritionist involved just as much?
well, unfortunately, this is another thing that is, she has diabetes, so her insurance should pay for diabetes counseling. And the nutrition literature is just exploding with lots of information about the importance of basically a little bit different than what I was taught and what I'm sure you were all taught of what's good to eat and what's not good to eat. So it's changing rapidly. We do try to get many of our patients that I see, we do try to get a nutritionist involved. Again, it's not covered by insurance generally for an outpatient. Unless you have diabetes, then you might be able to get it covered. Not all insurances even cover it then. So unfortunately, we have that team that sometimes it's a little bit harder to access some of those different disciplines in the team. Along with the fact that this patient, it's a little bit off the subject, but she needs to have physical therapy. She has chronic back pain, and really most people kind of hesitate about physical therapy because they think it's going to hurt more, but it's important to get the physical therapy to be able to do what we can do to make those muscles stronger so that the back doesn't hurt as much and is less likely to have the injury. So, other team members are important. It's not all about the medications by any means.
And that's a good point. So you guys will be, as part of this course, some of you have already done it, participated in our CMIT team meeting where we've presented a complicated case with a drug list, very much the same length as this one, and problems. And hopefully, what you'll learn from that and see demonstrated in that is, like Sue said, it's not just the medication issues. It also has to do with whether they can get the medications and what can the social worker tell us about their financial status as far as that goes, or their family situation, and all of the things that you guys are bringing up, really pointing to the benefit of this interprofessional approach, which is hopefully a big takeaway from this is all team members are equally important in solving these complex cases.
So I think John has his hand up.
Sorry about that. Let me lower it.
Okay, that's okay. Any other questions? A great discussion. I'm so happy to have you all so engaged.
Just one more thought. The other thing is that this person has diabetes. Diabetes can affect the kidneys, correct?
Yes.
Okay. Statins also affect the kidneys.
Yeah,
I found out from personal experience.
it can. It's kind of a rare side effect. So most of the time with diabetes, we oftentimes do use a statin because diabetes can increase stroke risk, increase
Right.
cardiovascular risk. So the statins help to prevent that. But you're right, we have to monitor and make sure that that's kind of a rare reaction, but it can occur. We do have this patient on a medication that helps to protect the kidneys. So that is the lisinopril.
So that does help protect the kidney?
Lisinopril does. Once a patient gets to a certain degree of it works better when you have a little bit of damage. It prevents the damage from getting any worse. So once the patient gets what we call microalbumin in their urine, which means their kidneys, it's a marker that their kidneys aren't working as well, then we have several drugs, and lisinopril is one of them that can help to prevent further damage.
So is she just on the one statin?
Yeah, she's on the atorvastatin.
Okay.
And statins have a bad reputation, but
Right.
That they have a lot of side effects. I mostly see the muscular side effects. Those are the most common side effects that can occur. Some people can get liver side effects, but they have shown that to be very rare.
Right.
My opinion on statins is they used to say they take 5 years to work, but there's information out that they work much faster. And they have something they're doing other than lowering cholesterol that makes people live longer, is what the studies show. So if I can keep somebody on a statin, I'd prefer to do that. But if they're having side effects that are making them miserable, then the benefit risk ratio changes. And from what you said, with having something like a kidney failure or kidney problems while you're on the statin, I mean, if you're having one of those rare side effects, of course you have to stop it.
I see that there were the big issue with a lot of people getting coverage is insurance. Are there any supplemental programs to offset costs so that you can eat healthier, or if you need a medication and it's out of your price range and your copay, are there organizations you can reach out to for that?
Yes, absolutely. And I encourage to, so patients can change their Medicare D plan just once a year. I usually starts like in the first week of October, and it goes through the first or second week of December, where you can make those changes. And the Medicare.gov website is actually very good. So if the patient has a computer, to go in and put in your drugs and to look at the different plans and look to see which one is going to be the cheapest for you overall. You have to be careful about the deductibles, because sometimes the monthly charge looks really good, but you have a $500 deductible before that kicks in. So looking at that. And the other thing I would say about that Medicare.gov site is there's a telephone number. And those are the nicest, most helpful people that they have found to do that. That is one area that I think the government has done right, is that they really do have very helpful people on the Medicare.gov telephone line as well, if somebody doesn't have that. In addition, the Direction Home, they do have those services available as well, that you can call Direction Home, and they will help get you to somebody that will help you to pick the best plan. And your real question was about supplemental plans. And yes, there are supplemental plans that if you really decide you want to use this plan, I see the supplemental plans helping mostly with the more of the medical cost than the medicine cost. But I am aware of a couple of them are out there that will cover more for the medications. And then the other thing that goes along with that is a lot of older patients will qualify for that extra help, where they pay less for their medications, but they might not have ever applied for that.
I just want to ask, what what does the BID after the medication mean?
Oh, I'm so sorry. I should have updated that. So BID is twice a day. GID is 3 times a day. So it's kind of the way, but it is a shorthand. I originally gave this to people that were more medical professionals. I altered it a little bit, and I should have altered that. I'm sorry. Any other questions? So Michelle?
Yes,
That was
Did you
her.
have your hand
That
up?
was her. That was, she asked
that
about.
was me that asked about the BID.
Okay, all right.
So what is the, I'm seeing something else, PRN
I'm sorry, PRN is as needed.
as needed, okay.
So as needed for. So in other words, valproisolem is 3 times a day as needed for anxiety.
So TID is
Is 3 times a day.
3 times.
Yes, and I'll make a notation that if I give this to this type of group again, to make sure I update those.
Thank you.
Sure. All right. I just had a couple more slides that will be in your slide set. So just to let you know that I did include in here our plan for this patient. So let me see if I can get this to move again. I won't go through all of this, but just to note that there are other things, ways that we wanted to, this was what we put in place to happen with this, with the idea that it could not happen all at the same time. So these are the recommendations that were sent to the primary care physician. And I did also want to make sure, so there was 2 pages of them, so lots of things. And again, this isn't unusual that we find quite a bit with the medication list. This is a little bit more than usual because it is, and that's one of the reasons why I made it a case, but I would say not really that unusual. And then that last step is important for us to share this with the primary care physician so that they could reassess. So if this was my patient, I would be getting them back into the clinic or giving them calls to make sure that the changes that we made really worked for them. I think somebody brought up originally this patient's on a lot of medications that are causing drowsiness, and most of those medications would also contribute to falls, but stopping them is a process. We can't just stop many medications. They have to be weaned or else you'll get those withdrawal effects. So making sure that they're not getting any of those withdrawal effects, and if they are, to slow the wean down. That was all I had today. Any other questions?
So you can go ahead and unmute if you want.
Well, thank you guys for this. Was I loved all your participation and you had great ideas. So I appreciate all the input that you guys gave as well.
And I think, I guess, from my point of view and thinking about how, the takeaway for you guys is maybe, if you're not in a medical field, maybe more just out dealing in the community or something, and that slide she had about if you see a new symptom, think about the medications. That's an easy question to ask somebody who says, lately, or just like I've just been getting dizzy a lot, or something. And, an easy question to ask, did you start a new medication, especially with older people when you see how many they can be on? Or maybe they started taking some supplement or something like that. So, and again, it's not really on you to say, well, in my opinion, you should do this or that, but it really directing them back to their physician or, their primary care provider, and just say, you might want to ask about that, or let them know that this is going on and they may be able to switch over to something other or something like that. So.
And Sue, would you be able to provide us with a NeoMed resource for if all else fails for a med review, if somebody was requesting that?
Yes, absolutely. So I don't have it at the tip of my tongue right now. It is, but I have a telephone number that is in my email. So could you send it out when you send out my slides? Is that okay?
Definitely, yes. Any resources that, you want to provide, and I was thinking about that one, we will send out in an email to everyone after the lecture. So
Okay,
thanks so much.
sure.
Thank you, Sue.